to see everybody. Why don't we go ahead and get started? I'm sure we'll have others kind of coming in as we go. I really want this to be as interactive as possible. You have all done such fabulous work, and it was really, yeah, just a pleasure to see all the fabulous posters that have been shared, and thank you for putting them up on OSF. So the plan is for when it's your turn to share screen and spend a couple of minutes just kind of going through and summarizing your outstanding work, and then save a couple of minutes so that we can ask you some questions and stuff like that, because I think that's part of the most interesting part. So with that, I have down that Kayla, you're up first, talking about mobile stress monitoring, enhancing family well-being through technology.
Okay, great. Thank you. Let me share my screen. Okay. Oops. Let me put this in presenter mode. Okay, cool. You can see it all. All right, great. Well, thank you so much for having me here today. I'm super excited to talk about this study. We just wrapped up this study a few months back. And so a little bit of background. So we had parents and children download this app called Colliga on phones. And let me just start my timer so I have like a sense of how long I'm talking for. And so we had them download this app and we collected data for 2 months, really assessing family functioning. So things like how the parent-child mood and whether or not there was any conflict going on. And so the app collected surveys throughout the day, so twice a day for that 2-month period, and also audio recordings, which we will use for future studies. But within those audio recordings, it was everyday natural interactions. And so we hope to use that data and code it and assess family functioning as well. But for the purposes of this study, like I mentioned, it was a 2-month period where they collected data on surveys. And what we wanted to assess was, how does parent and child mood influence each other? So some preliminary analyses, we tested, does parent anxiety influence child anxiety? And we found that greater daily parent anxiety did influence and predict greater child anxiety. And then we also were really interested in emotion regulation. And so does the ability for parents to regulate their emotions in everyday life influence the interaction between parent-child mood. And so to assess this, we looked at parent just stress tolerance. And so what we found is it did not moderate the effects of parent-child anxiety. And so future directions will include looking at different mood states and also seeing whether or not it influences other things such as like daily conflict, and also testing lead lag association. So because we have this these daily surveys, we can say, okay, does parent mood influence next day child mood, or vice versa? And so we're really excited to start working on that in the future. Happy to take any questions.
Fantastic. Thank you so much, Kayla. Let's open it up for questions, either from our other presenters, or if anyone who's on wants to raise a hand or put a question into chat, or just unmute yourself. I think we want it to be conversational. All right, I'm happy to start us off, and then hopefully others will join in. Yeah, I'm super interested. One of the things going through my mind as you were talking was wondering, like, how much of these effects do you think are specific to parents versus if you had like peers, for example, being monitored, or if it was siblings or other types of relationships? Do you think results would be similar, different, and in what ways?
Yeah, I think that's a great question. And I think part of the interesting thing about this research is that children's mood is really influenced by so many different things, right? So parents, other peers. And so I think there's so much influencing it that it would be really interesting to look at, okay, what other things are most impacting the child's life? Is it school? Because, they're there most of the time, right? Or a good majority of their time. So I do think that like daily influences of peer to peer interactions would influence it. And I think something I'm really interested in is like stress spillover. So how do outside stressors such as like work stressors, for example, of a parent, how does that influence then their mood when they come home? And similarly for children. So if they have a fight with a friend and then they come home and they're really upset because of the fight with the friend, then how does that then influence the parent-child interaction? And so I think what's really interesting about using technology is being able to collect a lot of data and say like, okay, what are the influences that are most impacting the child? Because if it is peer-to-peer interactions, maybe that would be a place for intervention.
Super interesting. Other questions from the group?
Hi, Kayla. Thank you for the wonderful presentation. I think I have missed the information that you mentioned. So what are the information that were collected by the passive sensing?
Oh, yes. I didn't get a chance to get into that, but for the passive sensing, we have things like GPS location and proximity to different locations. So we can use that to assess like if they're physically close with the parent. And we collect other things like ambient light, noise. And so those are some other things that we assess through passive sensing.
See, yeah, that's interesting. I mean, I know that like, when it gets to collecting data, like, GPS data, so it's also about like, how you're going to save the data, so you can pass the regulation, IRB and things like that. So I wonder like, what's the way that you save those GPS data on the files, and also like how do you explain that in the IRB, so it will not be a concern for them, in terms of security.
Yeah, great question. So we do definitely report it all in the IRB, all the different data streams that we are collecting. And we say the software that we use, it was developed by the lab that I'm in. And so that software will collect the GPS data, and it's not locally stored, so it's automatically goes into like a secure database. Is that your question?
Yeah, so would it be, for example, specific to the zip code of the location, or because I can imagine that if it's too specific, like I don't know, like IRB might have the concern that, oh, so how could you protect their confidentiality, things like that, because location information is usually very sensitive. So, but I'm just curious whether you have like run into any issues, in terms of collecting GPS data in your
Yeah.
study.
Yeah, we haven't run into any issues, but I'm curious, have you run into any issues and anything that maybe we should keep an eye out on? We have developers that help us with developing the data streams and storing all of that.
Yeah, I mean, I haven't myself, but I just heard that maybe if the data will go to like a nation, I mean, like outside the lab, like maybe that would be an issue, because people mentioned that if you know the GPS data, so you kind of know the person's day-to-day kind of like trajectory and things like that. But I guess because you are kind of general population, like rather than like more sensitive population, so I can imagine that's like a lesser concern. So yeah, but I'm just curious. Yeah. But thank you
So
for
this is
sharing.
a fabulous discussion. I'm going to jump in just in the interest of time to make sure that we get through all of our presentations, but fabulous questions. And Justine, Kayla, I encourage you to like swap info and keep the conversation going so that, yeah, this is exactly what we're hoping to spur here. So this is fantastic. I do want to make sure that we get to hear from everyone. And Josie, you're actually up next. So I'm happy to introduce Josie, who will be talking about changes in adult digital health utilization following the COVID-19 pandemic.
Yep. Thank you, Bethany, for the introduction. So I'm going to share my screen. Could you see my screen? The poster?
You're good. It just
Okay,
loaded.
awesome. Okay. Yeah, so So for this project, so I used like a nationally representative data set, which is called the Health Information National Trend Survey, or HINTS, to analyze the persistence of digital health disparities among the US adults. Like the motivation to conduct this study is because we all know that following the COVID pandemic, there has been expansion in digital health engagement and utilization in the, kind of like worldwide. And based on the prior to COVID, like there was like a mounting evidence indicating the social demographic disparities in digital health utilization. And however, like to our knowledge, like the most recent data using like nationwide data sets were collected, were analyzed before the pandemic. Like, the latest where we know there's like in 2019. So we kind of feel, oh, that's interesting, to collect like up-to-date information about this question and see, after following the COVID, several years following the COVID, like, what might be the disparities that might still persist. And so we chose to use the HINTS surveys because it has done a very good job in terms of collecting a thorough digital health questions, and that, which is the focus of this study. And they have collected the data bi-yearly. So the most recent data that they has released is collected in 2022, and the sample size was 6,252, and all of them were adults. The 7 social demographic predictors that we're interested in were listed in the table. Definitely don't need to give in them, like, because I can imagine they are very straightforward. And just for the purpose of interpretability, we banalized each of those 7 predictors. And so the 5 digital health questions or outcomes that we selected included the one that listed here, like digital device ownership, whether they reported using internet for seeking health information in the past year, whether they have used a health or wellness app in the past year, whether use a variable to track their health activity past year, also whether they use social media to look for health information in the past year. And we fit all the predictors, all these predictors and each of these health outcomes into 5 binary logistic regression models. We also use the approach recommended by HINTS to generate the nationally representative estimates. And so here are the results, basic results of this study. And so I know there's kind of like some subtle divergences for different outcomes, but so you can see that I only listed the values of the odds ratio for the significant groups for each item. So across like, these 5 digital health outcomes on the, in general, we have found that like, factors such as age, annual household income, and education, as well as gender, they have the most significant impacts on, like participants' reports of digital health engagement and utilization. And also, like, what is also interesting is that the race, ethnicity, and rurality do not really present, like, those persistent disparities in digital health use, at least, in 2022. And so like the only exception was that for, using social media for health information. So we see that as compared to white individuals, the non-white individuals were more likely to use social media for health purposes. So it could mean like, different things. It might mean that, it could be like advantage for non-white individuals to use social media for them to gather information about health. However, it might also indicate that, like, related to prior literature as well, like, the non-white individuals, they might experience this more disadvantages in terms of accessing like the professional healthcare information resources that might kind of like, lead them to rely more on social media to compensate for this, gaps in their health information. But definitely, it's pretty limitative, but it's an interesting outcome. So to summary the results, so we found that, at least 2 years following the pandemic, COVID pandemic, the digital health disparities still existed among like a typical older man, especially age 65 years old, with lower annual household income and lower educational degree. And also the kind of observation that like this disparities has been kind of decreased or even disappear for race, ethnicity, and rurality, kind of like, break this kind of prevailing beliefs that, like digital health disparities existed for this group. But kind of, what we kind of like suggest that, oh, it sounds like that, following the COVID, the expansion of access to digital health have really benefited these groups. It indicated that, like, for the future, it would be more beneficial to direct the digital health resources and access to, this this group that we know that still experience this disadvantages in terms of digital health engagement and usage. Yeah, that's my take-home message.
Fabulous. Thank you so much, Josie. Let's open it up for a couple of questions.
Thank you. Yeah, I had two questions. First, I was wondering, with like the higher health-related social media use, I was wondering if like you explored at all any possible like negative consequences of using social media for health information, given that I think there is like a lot of health misinformation out there on social media, and it can be hard to like tell what is correct or incorrect. And then separately, was just curious like what you made of the fact that there wasn't really a difference between urban and rural. I was thinking like it seems like there's a higher need for services in rural areas, but maybe there's like higher knowledge about digital options in urban areas. I don't know, but yeah, if you have any thoughts on those, I'd be very curious.
Yeah, thank you for the questions, Carolyn. So yeah, that's a good question in terms of like how to explain social media use for health. So you're right, like, that was also our consideration that, it could also mean, kind of like, this misinformation, we know that existed a lot, in social media, but at the same time, those misinformation that can also exist in the other outcomes that we explore here, like, using internet, we know that internet that can also, generate a lot of like, misinformation there. So, so for us, so I would say that, like, just for the scope of this study, we will not be able to answer this question or whether it's like a good or a bad thing, but it's kind of like more exploratory that to present this, recent, like up-to-date, kind of like, information to the community. So it's kind of like could mean that we need to it's kind of like, the fact that, like the non-white individuals that they rely more on social media for those information. And that could be like, many motivations, but it's hard to tell, whether it would be a problem. I think it also like varies across different individuals, but in the future, like it would be more helpful to offer like, education on, especially, maybe non-white individuals, or, how to correctly use social media to help them find the reliable health information. And your second question, yeah, like in terms of the rurality effects, that also like, we found is that results was interesting. So I think it could also be like many explanations. One explanation could be that, as compared to the urban folks, like, like those living in rural areas, like they might have like less access to in-person visits. So that might be like, higher motives to, recommend them, digital health tools. Like when I'm like, I'm doing my internship at Charleston Consortium. So many of my patients, like for my for virtual visits, like they live in the rural areas in South Carolina and Georgia. So I can definitely see this kind of like this increasing needs for this kind of virtual services like digital health tools, especially for people who live in the rural areas.
Thanks. That's really helpful. Yeah.
Super interesting. Wonderful. Well, thank you for sharing the insights, because I had the same question on the rurality, because I was thinking of broadband issues being a challenge and stuff like that. So interesting to balance that with sort of the greater need for that to be the delivery pathway kind of piece that you're pointing out. Wonderful. All right. Well, happy now to introduce Malin, who's going to talk about comparing in-person and online delivery of mindfulness-based cognitive therapy for Black adults with PTSD and depression. Does delivery format influence outcomes?
All right. Well, thank you so much for this nice introduction and the previous presentations that were very interesting. I hope you can all see my screen. Yeah, so to start off with, the study is based on a previous randomized controlled trial that was conducted by my internship supervisor and principal investigator of the study, Dr. Abigail Powers-Lott, whose data I was able to use, which I'm very grateful for because it's very good data. This study was based on. So to kick it off with, urban dwelling Black adults that also experience being affected by a low socioeconomic status are disproportionately often exposed to traumatizing experiences and therefore also resulting PTSD and depression. However, this population also largely lacks access to convenient treatment. And in this previous RCT that was conducted by Abby, she delivered mindfulness-based cognitive therapy, which is found to be very helpful for both PTSD and depression, exactly also in this population, in an accessible primary care setting, which is the Grady Memorial Hospital in downtown Atlanta. This is a huge site where specifically urban dwelling Black adults seek help in medical treatments. And in order to examine the research question on the effect of MBCT for Black adults on PTSD clusters and depression, we were able to recruit participants from the waiting room of the Grady Memorial Hospital in order to supply them either to a waitlist control condition or 8 weeks of mindfulness-based cognitive therapy. However, due to the global outbreak of the COVID-19 pandemic, this randomized controlled trial had to be transmitted from an in-person delivery in the rooms of the Grady Memorial Hospital to a digital delivery. And this data set therefore offered the unique opportunity to compare the patients that received online MBCT and in-person MBCT. So we ended up with a sample of a total of 80 Black adults. The sample was predominantly female, and we measured self-reported PTSD symptoms, but also clinician-administered scales to measure DSM-5 PTSD symptoms and the Black depression inventory. And on the data, we conducted mixed model analysis where we, in a second model, included the delivery format as a moderator. And the study resulted in one significant effect that we found, which is that now leaving the moderator completely out of consideration, MBCT for Black adults that are urban dwelling and of low socioeconomic income, when delivered in a primary care setting, was significantly decreasing avoidance symptoms in PTSD. And this effect, however, was not moderated by the delivery format. So no matter which condition you were in, whether you were in the online or the in-person condition before or after the pandemic, you would get a significant relief from your PTSD avoidance system through MBCT, which is a very desirable outcome because this indicated that there's no observed benefit or drawback of online or in-person mindfulness-based cognitive therapy, meaning both were equally effective in reducing PTSD avoidance symptoms. However, and since this is the only significant effect we found, you could say that 8 weeks of mindfulness-based cognitive therapy, regardless of how you deliver it to the people, might be a good place to start it when treating PTSD and depression in Black adults that are urban dwelling and of low income. But this might not be all the treatment they need in order to experience significant relief from their PTSD and depression symptoms. However, the lack of more significant findings might be due to small sample size, which might have led to the study to be underpowered, and due to, for example, the sample being predominantly female, there might be a lack of generalizability. However, And as you can see, like as the take-home message in the middle of the slide, you can say that MBCT in Black adults with PTSD and depression definitely decreases avoidance in PTSD as a good starting point. And this was achieved both online and in person, which is a promising finding when considering future delivery of MBCT that is online. Yeah, I'm open to any questions or remarks you have about the poster. And of course, for you to take just like a few moments to scan through the poster and read through everything that might need some more clearance. So, yeah.
Wonderful. Thank you, Mel. Yeah, this is that case where you're like thrilled to get a null finding, right? You know, because it's so nice to have those equivalent treatment options to share. So fantastic. Well, we have time for 1 or 2 questions. Let me open it up.
Yeah, fantastic talk. I'm curious a bit more about the format of the online. So was this like a telehealth format, mimicking face-to-face as closely as possible, or?
Yeah. Okay, so the groups were aimed to be held as small as possible with no more than 5 attendees per group. And it was rolling admission. So in the end, everybody enrolled in the study would have received MBCT. So yeah, there were small groups with 1 or 2 therapists that were leading the session. So the ratio of therapists and group attendees was also pretty even, or like pretty nice, I would say. And it was held via Zoom once a week for 2 hours with a short break in between. Does that answer your question, or do you need any more clarification or anything?
Yeah, I guess I was just wondering like what sorts of materials might have gone along with, and if that differed substantially from what you might expect in a face-to-face group. So basically, did the pivot really affect the treatment aside from the face-to-face component?
So actually the treatment that was delivered online was not significantly adjusted to being held in an online format in the way that the elements were not significantly changed. So meditation was, for example, still held online. You would say that this might be a practice that you would prefer to be delivered in person to the attendees of the group. But that, for example, was still incorporated. Then since mindfulness-based cognitive therapy is still cognitive therapy, you would also receive leaflets with psychoeducation, so like very classical cognitive therapy components were still incorporated as well. So it was more or less transferred one-on-one with IRB approval and any other like kinds of approvals that you might need. It was transferred to Zoom. It was also very spontaneous because the outbreak and the lockdown happened quite fast, as you might remember. But everything was IRB approved before the study went online, and there were no significant drawbacks or changes to the program.
Great, thank you.
Fantastic. Thank you. All right, I'm going to keep us moving just to make sure we have time for all of these fabulous talks. Nate, you're up next talking about comparing treatment response in community college students with elevated PTSD symptoms undergoing digital therapy, a quasi-experimental approach.
Great, thank you for that introduction. Let's see, is this large enough to view when I share the full slide?
If we make our screens big, I think it works. But if you take it out of presenter mode, then I think it'll, or put it into presenter mode, then I think you'll get, there you go. That's much better.
This is better here?
Yeah,
Okay.
much better. Thank you.
Okay, great. Well, thank you. Yeah, excited to talk about some of the work we're doing at University of Arizona. I work with Dr. Zach Cohen in the personalized treatment lab, and really want to frame this entire sort of line of research around the digital therapy platform that Zach co-developed at UCLA as a postdoc. We're broadly using the digital therapy in a lot of ways, but the 2 main goals are really to increase access to evidence-based treatment, and then also to collect really highly granular both treatment data and also process level data to better understand what might work, better for certain individuals or how treatments work. And so this is just some exploratory analyses, kind of digging into some of the types of analyses that we're hoping to do more of in the future once we collect more data. Lots of people are using the digital therapy currently, but we're getting pretty granular with some of these comparisons, and so hoping to collect more data to be powered to do this type of work. So essentially, taking PTSD as an example, we've got a sample of community college students who are undergoing a digital therapy treatment trial, and they go through this adaptive symptom assessment at baseline to determine which package they're going to receive. And sometimes people will not directly match into one of the predefined packages that is available. And so in that case, they get to select which package they're gonna do. And so we looked at people who had similar patterns of PTSD symptoms and other comorbidities who either selected a trauma package or selected a different package. So targeting something like social anxiety or depression, and wanted to see really, does completing a treatment that targets a disorder have better outcomes for those individuals compared to other treatment. And so we used a quasi-experimental approach to look at that, and started out with just exploring the data. So I can zoom in here a little bit just to show the average trajectories by treatment target. So the red line is people who did not engage in treatment targeting PTSD symptoms, and the blue line is people who were in a PTSD package. We also looked at some individual growth curves in the average trajectory just to get a sense of how treatments were responding over time. And so, yeah, we can see that, there's some difference in baseline levels where the non-PTSD group was a bit higher, and the PTSD group is a bit lower, and then decreased a little bit faster. In terms of the models that we ran, so started out with just an unconditional means model, just to take a look at whether there's variability in the outcome, both at between and within person levels, and we found that. And then we added time, so we looked at the week that people were in treatment. They completed PCL assessments every 2 weeks for up to 40 weeks. And we found that there's a significant effective time, suggesting that there's substantial variability between participants, and that that would justify adding a fixed effect into the model to try to look at the differential treatment group. We didn't find anything significant there, but the sample size was pretty low and number of observations. And so we're seeing some trends in the right direction, and none of these were intended to be confirmatory analyses. We just kind of are at the stage where we're getting into this data, and we're really excited to see what might be going on and try to explore different trajectories and identify things that might be working about personalized treatment to test later. Yeah, happy to answer any questions. I also have a lot more slides on Rainfrog, which is the digital therapy platform, and anything that could help clarify, but thank you for your time.
Thanks. Yeah, and that's if you follow that QR code to get those other pieces.
Yep. So if you go
Awesome.
to this QR code, yeah, that's the Open Science page for Rainfrog.
Perfect. Wonderful. Let's open it up for questions. I'm happy to get us started. I was really curious about really interesting data. And I was curious about, sort of your takeaways and future directions. And you talk about sort of the value of looking at module completion and tool engagement in the future, and some of those type of pieces as predictors, which makes perfect sense. I am curious though to, I guess, press a little bit on what aspects of engagement do you think are going to be the important pieces here that, because is it really going to be about time and whether you complete things, or is it going to be about some other indicator of processing? Yeah, I'm just curious, especially as you bring in that piece of people's treatment choice that you're looking at and stuff like that.
Yeah, no, that's a great question. I'm really excited to get into the tool data. In addition to engagement, we have symptom ratings, pre-post tools. We can see, is this technique acutely impacting someone's mood. And then we have a lot of just text description for qualitative analyses to try to see if there's patterns in the way that people are acting. And these are all pretty standard like therapeutic techniques. So Zach and colleagues at UCLA, they adapted things like, you know, positive affect treatment, behavioral activation. And so the modules are like kind of gold standard CBT type modules. And so looking at how those tools and how, you know, both the quantity of the engagement, but also the quality and how people are really interacting with them. I'm really excited to look at that.
Fantastic. Great. Well, thank you so much, Nate. Yeah, such interesting work everyone's sharing. All right, I'm happy to move us on now to hear from Caroline, who's going to be talking about does recruitment source matter, comparing diversity among participants recruited from social media forums versus other sources for a nationwide digital body dysmorphic disorder study. Thanks.
Cool. Let me just. Okay. We're having some. Okay, I guess I'll just.
You're actually pretty good. We can see it well
Okay.
there. So
Okay,
yeah.
great. That's good to hear. Awesome. Well, yeah, so this project compared participant diversity between two recruitment groups in the context of a digital body dysmorphic disorder study. So we had two categories of participants, those recruited via social media forums and those recruited via other sources. And so we thought the social media forums might be more effective for reaching minoritized and underrepresented folks, as these other sources, for example, research and clinical referrals, hospital email blasts, research study websites, might require things like access to medical touchpoints, trust in the medical system, even free time, bandwidth, knowledge to look for research opportunities. And all these factors might potentially overlap with financial resources, education level, racial privilege, etc. So we did the social media recruitment via Reddit and Facebook, like subreddits and Facebook groups, using IRB approved language and this really excellent like ethical framework as a guide. And there are a lot of subreddits that actually revolve around concerns and compulsions present in body dysmorphic disorder. So for example, r/am I ugly is one of many subreddits where people like post selfies and ask for reassurance. So we ended up recruiting more than half of our participants via these social media forums. And we compared between the two recruitment groups the proportion of folks with a minoritized racial ethnic identity, an education level lower than a college degree, and of note, not currently in college, those receiving welfare as a source of economic support, and those with a minoritized sexual orientation. And so we found that there was a significantly higher proportion of folks with an education level lower than a college degree in the social media recruitment group. And there were no significant differences with respect to these other factors, although you can see there was like a non-significantly higher proportion of those receiving welfare and those with a minoritized sexual orientation in the social media recruitment group. So yeah, those were the main conclusions from this project, with some limitations due to the small sample size, including like an increased chance of type 2 error potentially, and an inability to examine these recruitment sources and the different demographic variables in more nuanced ways.
Fantastic. Yeah, I love this because I feel like it's such a really concrete empirical way to try to understand the ways that we're getting our samples and the implications that we all talk about, like digital mental health as a way to increase access. And this is a really nice way to kind of think about how do we bring that to life. So that's awesome. Questions that people have? All right, well, I'm happy to get us started and then we'll see if there's time for others. I'm really curious to hear, just given the differences in the samples that you were seeing, like, did you find that you needed to use different recruitment strategies for the social media forums versus other places in terms of like how you described the study and what was involved, or how you described the program, or, you know, incentives, or just, you know, all of those kinds of things? Like, in what ways did you feel that your messages needed to be modified to match the recruitment pathway.
Yeah. So we pretty much kept the same message for each individual like subreddit or Facebook group. But we kind of in line with like this article that I just put here. We would message the moderators of the group first and say like, is it okay if we post here? And then we would indicate like, hi, I'm a researcher looking for people who might be interested in this study. So it was kind of like more informal language because it was pretty much just putting a post in this group and being like, hi, here's this if you're interested. But we still put all the info about the study and everything. And with these, I suppose it was a little bit more like advertisement soundy just because it wasn't like a direct message in a group in the same way, if that makes sense.
No, for sure. Other questions? We have about a minute. All right, then thank you very much. Olivia is one of our people who actually is in Australia right now. So she sent a recording because of the however many hour time difference that it is. So we're going to cross our fingers and hope that I can share the recording of her talk here and that will work. And her talk is Lessons Learned from Co-Designing a Just-in-Time Intervention for People Who Have Experienced Trauma. And here we go. All right.
Hi everyone, my name is Olivia. I'm sorry I can't be there in person. It is 3 o'clock in the morning for me.
3 o'clock in the
so
morning.
I'm sound asleep right now. But I'm looking forward to catching up on everyone's talks, and please scan the QR code to connect with me asynchronously about anything you're interested in. And I just like to start my talk by acknowledging that I'm speaking to you on the lands of the Wurundjeri Woi-wurrung people, and I'd like to pay my respects to their elders, past, present, and emerging. So in the minute or so that I have with you, I just wanted to share with you a bit about an approach we took to developing a new just-in-time adaptive intervention for people who've experienced trauma. So our pilot data had showed that digital mental health tools were feasible in this population, and that there were some really unmet needs around managing, in particular, dysregulated anger. So while there's a lot of mental health apps available for the management of depression or anxiety, many of them are not trauma-informed. That's appropriate for a trauma-affected population, and very few, if any, help manage symptoms of dysregulated anger. So we took a trauma-informed approach to co-design. We had people with lived experience of trauma and dysregulated anger, iteratively creating and working alongside clinical psychologists, trauma experts, and software developers to kind of pair the evidence-based content that we thought supports, so we know supports symptom management, alongside the right look and feel and design principles. And not only was this really effective and resulted in, I think, a really a great prototype, but it also really informed the way in which we designed our evaluation. So it became really apparent early on that, how do we match and measure for the micro-randomized trial that we're running the right proximal outcome and our patients' experience in a way that also fits with the symptom improvement that we're trying to measure. So I think our findings really speak to how valuable it is to have people with lived experience as part of design right from the start, not just to get the right look and feel and design principles of the app, but also as a way to help present the content itself, and also to inform the evaluation and uptake, optimal uptake more broadly.
Wonderful. Yeah, great work by Olivia. So if you want to put any questions in chat for Olivia, I'll make sure that they get back to her. But I know that we are at 1:59, so coming up at the end of our time together. But thank you to all of our fabulous presenters. This was such a interesting mix of talks, and really appreciate hearing about everybody's fabulous work. We'll take a 10-minute break and then come back for our next set of programming. So fabulous work, everyone. Thank you.